Welcome back to the Head and Neck Oncology Journal Club. Today, we are looking at the Ferrari and colleagues in the European Journal of Cancer 2026 paper, Outcome of Different Treatment Patterns for Adenoid Cystic Carcinoma of the Anterior Craniofacial Area. And it's about treating adenoid cystic carcinoma over a span of years from 1984 to 2023. Adenoid cystic carcinoma of the anterior craniofacial region, including sinonasal tract, hard palate, nasopharynx, and soft palate, is the tumor that humbles you on follow-up. It creeps along the nerves, permeates bone, and stays quiet because it barely provokes inflammation. The standard has been surgery plus radiotherapy for decades. But the foundational papers behind that standard are old. They predate endoscopic approaches, predate IMRT, and predate proton therapy. This cohort tests the old standard against modern tools. About the cohort, 578 patients, median age was 54 with slight female predominance. 3/4 were sinonasal and about 2/3 were low to intermediate grade. At 20 years, the cumulative incidence of local recurrence was 74%, and over half had developed distant metastasis. This is a disease that you manage across decades, not one you cure and forget. They did something clever with the anatomy. Instead of relying on T-stage alone, they took 43 anatomical structures and used hierarchical clustering to find 4 natural spread phenotypes. From the confined sinonasal disease to pterygopalatine and infratemporal fossa extension, to central skull base and extension to inferolateral area, reaching the cavernous sinus and craniocervical junction. That clustering then balanced their comparison groups. What is the central finding? The headline is the gross total resection followed by adjuvant therapy, especially proton therapy, gave the best local control. But here's the part that should change behavior. They compared R2 resections, where you have left macroscopic tumor, against definitive non-surgical treatment. No advantage. 10-year local recurrence-free survival was 28% for R2 cases versus 16% for biopsy-only cases going straight to radiation, and that difference was not significant. P of 0.22. So, if you go in, leave gross disease, and the patient still needs full dose radiation afterward, you have added morbidity and delay without buying local control. The authors are direct about it. R2 surgery should be avoided. Operate when you realistically achieve a gross total resection. If you can't, refer for particle therapy. Now, what is this gross total resection philosophy? There is a conceptual move here worth pausing on. They lumped R0 and R1 together as gross total resection. Why? Because in adenoid cystic carcinoma, negative margins are partially an illusion. It's almost never possible. Their own unpublished data suggest microscopic tumor foci sit roughly 3 centimeters out from the visible tumor, and about 15% of the time. A national database study they cite found positive margins in over half of the sinonasal adenoid cystic carcinoma cases. So, the R0 versus R1 distinction often dissolves. What matters is whether you got out everything you can see, and then radiation handles the microscopic residue. Now, the proton story. Among the 110 patients treated, definitely without surgery, complete response at the first postoperative imaging was 74.5% with proton versus 52% with photons, significant at P of 0.023. And concomitant chemotherapy to protons response climbed to 90%. Two important caveats. First, the proton subgroup were small, and once you adjust for confounders in multivariable analysis, the proton advantage loses statistical significance. So this is a signal, not proof. Second, and this is the elegant observation. When you look at the slope of local failure over time, responders to non-surgical treatment fail at the same pace as patients who had surgery plus radiation. The gap between groups is driven entirely by the non-responders, which means if we could predict who will respond, we could potentially spare select patients surgery altogether. That's the future this paper is pointing at. Toxicity: 10-year incidence of grade 3 or higher adverse events in non-surgical group was 36%, and it didn't differ significantly by modality. Mucositis, maxillary bone necrosis, and ocular complications led the twist. Worth noting, these late events accrue well beyond 5 years, so short follow-up underreports them. About the limitations, it's retrospective. The treatment groups are incomparable by nature, and selection bias is unavoidable. Sicker, more extensive tumors went non-surgical. Techniques evolved over 39 years span, and for a disease this indolent, even 5+ years of median follow-up may be too short. Propensity matching and multivariable modeling help, but this isn't a trial. Bottom line, 3 things. 1, planned surgery only when gross total resection is genuinely achievable. The specific red flags like R2R, infratemporal fossa, parapharyngeal space, middle cranial fossa, orbital apex, petrous bone, cavernous carotid, and posterior fossa dura. Secondly, if you will be leaving gross disease, R2 debulking buys nothing over definitive radiotherapy. Send the patient to particle center instead. Third, give adjuvant radiotherapy to essentially every primary case and treat proton therapy as a real definitive option for selected unresectable tumors. But we know proton therapy may not be available everywhere. That's the episode. The paper is open access in European Journal of Cancer. The link and the DOI in the show notes. If this was useful, share it with your oncology colleagues, and you will be arguing with them at your next tumor board. See you next time. Thank you.